complications are health issues that arise after surgical removal of part or all of the stomach, gastrectomy. These complications can range from immediate postoperative issues to long-term nutritional and metabolic consequences. Below is a detailed overview. 1. Immediate postoperative complications. These complications usually occur within the first few days to weeks after surgery. A. Bleeding can occur at the surgical site or from staple lines. Symptoms include low blood pressure, increased heart rate, and signs of anemia. May require reoperation or endoscopic intervention. B. Infection. Wound infections, intra-abdominal abscesses, or anastomotic site infections. Symptoms include fever, pain, and redness around the wound, treated with antibiotics or drainage. C. Anastomotic leak occurs at the site where the stomach is connected to the intestine or esophagus. Symptoms: fever, abdominal pain, peritonitis, and sepsis. Managed by surgical revision or conservative treatment like drainage and antibiotics. D. Ileus, delayed gastric emptying. Prolonged paralysis of the intestinal tract leading to bloating, nausea, and vomiting. Usually resolves with supportive care, nasogastric decompression, and fluids. E. Pulmonary complications. Pneumonia, atelectasis, or pulmonary embolism due to immobility or surgical stress. Managed by respiratory therapy and anticoagulation. F. Thromboembolic events. Deep vein thrombosis DVT and pulmonary embolism are potential risks. Prevented with anticoagulants and early mobilization. 2. Intermediate complications. These occur weeks to months after surgery. A. Dumping syndrome. Rapid gastric emptying into the small intestine. Early dumping occurs 10 to 30 minutes after eating. Symptoms include nausea, abdominal pain, diarrhea, flushing, and palpitations. Late dumping occurs 1 to 3 hours after eating due to reactive hypoglycemia. Management: dietary changes, small, frequent meals low in simple sugars, and medications like octreotide. B. Nutritional deficiencies, common due to reduced gastric acid, altered digestion, and malabsorption. Vitamin B12 deficiency, caused by loss of intrinsic factor-producing cells, leads to anemia and neurological symptoms. Iron deficiency, resulting from reduced gastric acid necessary for iron absorption. Calcium and vitamin D deficiency can lead to osteopenia or osteoporosis. Management involves supplementation and monitoring. C. Gastroesophageal reflux, increased reflux of bile and stomach contents into the esophagus due to changes in anatomy. Managed with proton pump inhibitors (PPIs) or bile acid sequestrants. D. Strictures, narrowing at the anastomotic site causing dysphagia and obstruction. Treated with endoscopic dilation or surgical revision. 3. Long-term complications. These may persist or develop years after the surgery. A. Weight loss, common due to reduced gastric capacity and altered absorption. Can lead to malnutrition and fatigue. Requires nutritional counseling and high-calorie, nutrient-rich diets. B. Chronic diarrhea. May result from bile salt malabsorption or bacterial overgrowth in the small intestine. Managed with dietary changes, bile acid binders, and probiotics. C. Alkaline reflux gastritis. Chronic irritation of the gastric or esophageal mucosa by bile reflux. Symptoms: epigastric pain, nausea, and bile vomiting. Management includes dietary changes and medications. D. Small bowel syndrome, seen after extensive gastric or intestinal resection, involves malabsorption and diarrhea. Requires nutritional support and sometimes parenteral feeding. E. Increased risk of bone fractures due to chronic deficiencies in calcium and vitamin D. Long-term bone health monitoring and supplementation are essential. F. Cancer recurrence. If gastrectomy was performed for gastric cancer, there is a risk of recurrence. Regular follow-up with imaging and endoscopy is crucial. 4. Psychological and emotional effects. Anxiety, depression, or altered body image can result from the physical and lifestyle changes. Support groups, counseling, and psychiatric support may help. Management and prevention. Preoperative care, thorough assessment and nutritional optimization before surgery. Postoperative monitoring, regular follow-ups to detect complications early. Dietary adjustments, gradual reintroduction of food, focusing on smaller, nutrient-dense meals. Lifelong supplementation, vitamins B12, D, minerals, iron, calcium, and other deficiencies need to be addressed. Exercise and lifestyle. to maintain physical health and prevent bone loss or thromboembolic events. By understanding these complications and their management, healthcare providers can minimize risks and improve quality of life for post-gastrectomy patients.